Wonderful. Well, welcome to Shrink Sync, everybody. This is our monthly webinar that we host. We invite speakers with specialties to bring you wonderful information and provide you with a free CEU. Just a little bit about Shrink Sync before I introduce the presenter and you hear today's talk. Shrink Sync is a digital networking hub for therapists. We provide different subscribers who are on will provide referrals, client referrals to, oops, I shouldn't have that on. We have access to allowing people to do job postings and office-based postings. What's wonderful is we have a list of agencies and treatment centers on our directory, so it's easy for you to search for centers that are specific to what you're looking for. And we, of course, also have a community room for people to discuss or post questions and different things that may be of interest to invite other therapists to discuss certain items. And we do have a huge listing of CEU events in the area. So if you're ever interested in additional training or certifications, please make sure to look through the CEU events we have listed and feel free to post any events that you would like to promote as well that offer CEUs, or at least that they're for therapists. And I do want to remind you guys, on January 27th, which is in 2 weeks on a Tuesday, I'm going to actually offer a free CEU through our Shrink Sync. And what we're going to do is discuss digital marketing for your practice. And I'm going to go over ways that all of you can use Shrink Sync to your benefit. I know sometimes there's confusion with what to do and how to do things. So we'll go over that, and we'll go over some tips on digital marketing as well. So for right now, I would like to introduce Kathy Harris. I'm going to read her bio, and I love everyone chatting over here. It's wonderful. Kathy Harris is an LCSW in San Diego. She's currently in private practice. And her focus for treatment is trauma, including complex PTSD and dissociative disorders. She trained with Colin Ross, MD, at Timberlawn Psychiatric Hospitals and Patient Trauma Treatment Unit in 2000-2001. She has engaged in clinical work in many settings, including inpatient trauma treatment, intensive outpatient program adults and adolescents, in-home, agency, private practice, crisis center, Felton Crisis Center, residential treatment for adolescents and adults, dual diagnosis for civilians and military personnel. She is an educator in the field of trauma-informed care perspective. Kathy provides face-to-face seminars, consultation, and online continuing education for professionals seeking to expand their knowledge and understanding. She writes all exams for Trauma Revolution, an online CEU provider. Kathy has been presenting on trauma in topics primarily to small organizations and individuals for over 10 years. Please help me welcome Kathy Harris. And I think Kathy is going to be available by phone only. We're having technical difficulties with getting her on camera. So you'll be able to hear her, and I'll remove myself from the video right now. So I hope you enjoy our presentation today. Kathy, you're on.
Kathy? Kathy, we can't hear you. So if you can either dial in again, or I'm not sure what happened to your audio. Can you, Kathy, can you type in the chat box and let me know what is what's going on, or what you want to do if you want to dial back in?
Just let me know she's going to dial in again. So you guys just have patience. Give us 1 minute. She'll be on, and you'll be able to hear her.
Okay, great.
Okay, great.
Thanks for your patience, everyone. Hi everyone, Kathy is dying again, so just hang in with us for a few minutes and she should join us really, really soon. If you have any questions, go ahead and type them in the chat box and we'll be more than happy to answer while you wait.
Good morning. Can you hear me now? So I'm just, shall I go ahead? Traumatized right now. So this is Make the Shift with Your Trauma-Informed Mind. Thank you all for your patience. We're going to talk about trauma-informed perspective and trauma-informed thinking. Hopefully some of you have heard about that phrase. It's a big movement that's going on in our various fields and in other fields around the world at this point. What is it? This is my definition of trauma-informed mind or trauma-informed perspective. It's a way of thinking. It's based in compassion and a recognition that all humans experience trauma in their lives. We all have experienced some kind of trauma in our lives, whether it happens directly to us or in our environment. We are in presence of trauma, and sometimes we can feel hopeless and helpless and like our lives are in danger. So when we are a trauma-informed thinker, we do recognize this, but we also recognize that all humans possess strengths, and if they're survivors of ongoing or outright event abuse or circumstances, they have already demonstrated courage and resiliency. But their victimization is acknowledged and validated, and their assets are utilized in an empowerment process. Really, it's about working with the understanding of who the person is, what they're coping with, and where they're coming from. So think in terms of the dog whisperer or a horse whisperer. Those persons are, rather than imposing their way of thinking on that animal, they have gotten to know the animal and the species, and then they work that knowledge. And this is what we're doing when we become a trauma-informed thinker. We become a people whisperer. So it's all about a paradigm shift. Many of us have been trained under mostly the medical model, or if we've worked in hospitals, facilities, agencies where there is treatment via medication, we've worked with doctors, and the medical model that is primary there. However, that model promotes more of an illness model who will treat you. It's all about what's wrong with you. But trauma-informed mind primarily pays close attention to the person's social history and what they have experienced, and what are the after effects of their social history. It's all about what happened to you. So it's more of an injury-focused model in that, think about if you broke your arm, you went and you got a cast, who's going to put the cast on? The nurse. And then you're going to have that cast on for a few weeks, and then you're going to go back, they'll take it off, and you're probably going to do some physical therapy. The expectation is you're going to heal, you're going to be able to move on from that. You'll have support with a physical therapist perhaps, but you're going to do the work. So this is more the trauma-informed way of thinking. But why is this so important? Why are we even talking about it? That's what we're going to cover this morning. Along with these other subjects, we're going to learn about where it came from, who promotes it, what will change when we're in a trauma-informed way of thinking, how can we get there, what gets in the way for some of us, and what about our own self-care. Mark Epstein is actually an MD. PhD is wrong. He's a psychiatrist in New York City in private practice. He practices from a Buddhist viewpoint. And he wrote a book called The Trauma of Everyday Life a couple years ago. And he states that all of us are subject to trauma. Trauma is not just the reason. We have to broaden our understanding of what trauma is in the first place. It doesn't only happen to some, it happens to all of us. And as we know in the news recently, there are daily, there are traumatizing incidents that are happening all over the world, sometimes in our own hometowns. Sometimes when I do face-to-face presentations, individuals will kind of take issue with this idea that we all have had trauma. They'll say to me, well, I've never been abused. Why can you say I have trauma? So I'll ask them, do you have children? And they'll usually say yes. And I say, do you send your children to school? And then they'll get a look on their face and they understand completely what I'm talking about, that we all experience trauma because we have to go out in the world. There are things going on outside of our control. But where did this come from and how did it develop? I've been working with trauma from the beginning of my career in this field over about 20 years ago. I did my training, as Anita said, with Dr. Colin Ross. I thought that out. I wanted to work with people who had trauma. I recognized as a therapist. I had, in my schooling, I had actually looked at my own life experience and used papers and projects to work through those things. And I wanted to be able to bring my understanding to the field. So several years ago, I was in Iowa and trying to promote the idea of a dual diagnosis program that would work with the trauma, and I was doing presentations on this and research and going with the doctor and doing presentations, and found a study, or rather not a study, but a document written by a woman by the name of Ann Jennings. She's a psychologist out of Maine. And she's been working for 27 years, over 27 years, to spread the word about the effects of trauma on people in all kinds of human service settings. And so this is an updated version of this Models for Developing Trauma-Informed Behavioral Health Systems and Trauma-Specific Services. It's an outline of various treatment models and statistics. It's just chock full of all kinds of good information. You can go online and download this PDF. But this was I think the original one was a couple or 3 years earlier than this. I ran into this term, trauma-informed. I had never heard this before, and I really liked it. And I got to know something about Ann Jennings' experience. Her daughter had been in the mental health system from the time she was about 12 years old till she was 31 and completed suicide at that time. In her treatment, her mother found out that she had been abused sexually by a babysitter. And the story is quite chilling. The mother, as they sought help, as the mother looked back on it, as Ann Jennings looked back on it, she realized that nobody had ever really taken her daughter's trauma experience into account, and really it was the main thing that needed to be looked at. And then the ACE study, I hope some of you have heard of it. It's the Adverse Childhood Experiences Study. And it was done, I believe, back in the late 90s by Kaiser, surprisingly. Kaiser Permanente out of San Diego, the Centers for Disease Control, and a couple of researchers, a couple of doctors. At Kaiser, they asked over 17,000 HMO members who were undergoing comprehensive physical examinations to provide detailed information about their childhood experience of abuse, neglect, and family dysfunction. There is just a whole industry that's developing out of the understanding of the importance of the ACE study. So we're going to talk about it here in a few more minutes, a little bit more about it. But it actually, the findings suggest that certain experiences in early life are major risk factors for leading causes of illness and death, such as cancer, diabetes, and other heart disease, other major conditions. And the Substance Abuse Mental Health Services Administration, or SAMHSA, created a document called Leading Change, a plan for SAMHSA's rules and actions, and they came up with several initiatives for improvement of health care. And one of these was trauma and justice, because of the fact that such a high percentage of people who are in substance abuse issues and such a high percentage of those persons have early life trauma that has really not been resolved. And so this is seen now as a justice issue. There's actually school for Master Social Work, Buffalo School of Social Work in New York. Actually, their whole curriculum now is trauma-informed, and they see this as a human rights issue. So it's not just about treatment, it's about a whole way of thinking. So this is where sometimes people get a little bit hung up. They think we're talking about a treatment modality here, but we're really not. We're talking about a way of thinking that this would really permeate everything that we, not only in mental health, but in school systems. In some school systems, trauma-informed thinking is being taught so that teachers, for instance, when children act out, they can, rather than see that child as bad and in need of punishment, they can actually talk about and think about what this child is maybe experiencing and learn better ways of working with the child. I worked in Tucson, Arizona for a while. I found that there was a judge who was requiring everyone in his juvenile court system to become trauma-informed so that they would be able to deal not only with the behavior of the children that were coming through the court, but with the reasons perhaps for that behavior. And they have better outcomes when they treat children along the lines of looking at their past. We're going to look for a moment at this little graphic. This is from an organization called ACEs Too High, The Truth About ACEs, Their Adverse Childhood Experiences. We're going to look actually specifically at the 10 questions that are asked as on the ACE questionnaire. But there are 3 types of ACEs, and that's abuse, neglect, and then household dysfunction. Household dysfunction includes that a person and a child might have grown up with mental illness in the house, perhaps an incarcerated relative. The mother might have been treated violently. There may have been substance abuse present. Abuse, of course, involves physical, emotional, sexual, and I would definitely include spiritual, although that wasn't specifically looked at in this study. Neglect, physical, and emotional. So what did they find? They found that 10% of the 17,000 participants had experienced physical abuse, 20% sexual abuse, and 10% emotional abuse. There were also high percentages of emotional and physical neglect. So that 64% of the recipients had at least one positive answer to these questions, one ACE, 28, much higher percent, or about 36% had none, 16% had 2. And so we don't want to get lost in these statistics. We want to recognize that this study was just monumental because of the fact that it's bringing to the fore what many of us in practice have known the whole time we've been practicing, that almost everyone that comes into our office has some kind of trauma in their life if we know how to ask the right questions. And this is a nice little graphic to have at hand so that you can kind of look at this and get a clue or get an idea of the statistics that come out of this study. At the end, I'll give you some contact information, and you can contact me for a list of resources if you like. We're going to look for just a moment at some of the specific questions that were asked in the ACE study. And again, this is something that you can go and download for yourself and have a copy. We're going to look at these specifically. I'm going to tell you why I feel this is so very important. I worked at a crisis center for a couple of years, and I was astounded to, we would do an intake and talk to a person for an hour, and always the people that were there in crisis would talk about the many traumas they had gone through in their life. And so, we clinicians would write a narrative of that. And so right after the narrative was a question: have you ever been abused, yes or no? So when I was reviewing other people's intakes, I would see this big narrative about all the trauma the person had experienced. And then the question, have you ever been abused, was marked no. And I would ask the clinician, but they had all these traumas, didn't you kind of gently challenge them and help them to kind of put together the dots here? And they said no. They said the answer was no. So this is one thing about trauma-informed thinking. If we get into informed mind, we'll understand that just asking a person, have you been abused, we're very often going to get no. For one thing, because defense, or denial rather, is one of our first and strongest defenses to trauma. It's a human thing that we do. We don't want to be seen as a victim. And so trauma-informed thinking, we help people understand it's not about focusing on you being a victim. It is about focusing on the reality of how your brain may have been affected and how your life may have been affected, so we can help you recover from it. So some of these questions are, did a parent or other adult in the household often or very often swear at you, insult you, put you down, or humiliate you, act in a way that made you afraid that you might be physically hurt? You can see that's very different from asking, were you abused? Did a parent or other adult in the household often or very often push, grab, slap, or throw something, ever hit you so hard that you had marks or were injured? Did an adult or 5 years older than you ever touch or fondle you, or have you touch their body in a sexual way, or attempt or actually have oral, anal, or vaginal intercourse with you? Again, very different from where you sexually did. Did you often or very often feel that no one in your family loved you or thought you were important or special, or your family didn't look out for each other, feel close to each other, or support each other? Did you often or very often feel that you didn't have enough to eat, had to wear dirty clothes, and had no one to protect you? Your parents were too drunk or high to take care of you or to take you to the doctor if you needed it. So I'm not going to read all the rest of these questions and how they would help people really get down to the issues at hand versus just asking, were you ever abused? A trauma-informed thinker will think in these ways. They'll learn to ask these things in such a way as to not perhaps trigger a person into flashbacks and having a bad experience right there in your office, but we will learn how to ask those things in such a way as to offer hope to the person and help them kind of, like I said, kind of connect the dots. Another graphic of the results of ACEs. Again, having many ACEs may lead to teenage pregnancy, high incidence of cigarette smoking, addictions of various kinds, so this adoption of health risk behaviors, the high risk behaviors, cognitive impairment can result in disease, disability, and social problems. I have worked for quite a few years in private practice in Iowa, and about half of my clientele were Medicaid, Medicare folks who were very often on disability for mental health reasons and had never been able to work. And they'd come from families where it was just transgenerational. It was generation after generation after generation of trauma and addictions and all these high-risk behaviors and various health problems that people contended with. They seem to keep passing these things on to the next generation. So I'm going to look for a moment at who promotes trauma-informed mind. These are some of my heroes. You may know of some other persons, but these are some of the ones that have really stood out for me, people who I follow their writings, buy their books. On my website where I provide CEUs, I have many of these books in the form of exams, so read a book and get CEUs for it. So Bessel van der Kolk is a doctor who has been in practice on the East Coast for over 40 years. His first work was with veterans back in the 1960s, before there was even a PTSD diagnosis, and he had difficulty working within that system because he didn't have any support or anyone around him understanding what he was seeing was that the trauma had everything to do with the diagnoses that the veterans were receiving. His latest book is The Body Keeps the Score. It's about the somatic nature of trauma. He's doing a very large study on the East Coast at his organization, Trauma Justice Center. They're studying the use of yoga for trauma. I just posted on my private practice website some YouTube videos about this, and you can go on YouTube and just search yoga for trauma and get all kinds of good stuff. So Judith Herman wrote in Recovery and came up with 3 stages for treatment that most of us kind of generally follow even now. And those stages include establishing safety, reconstructing or telling the trauma story, and then restoring the connection between the survivor and his or her community. So that's a model that many of us who treat trauma do use, and many of us don't even know that it came from her. She worked closely and still works closely with van der Kolk. Dr. Bruce Perry is a child psychologist, or psychiatrist rather, and a neurobiologist. His Child Trauma Academy in Houston provides treatment and does a lot of research on the effects of trauma on brain and learning. Christine Croteau wrote Healing the Incest Wound in 1988. She has written many recent publications regarding complex PTSD. Complex PTSD is a diagnostic category that Dr. van der Kolk has written criteria for, sent it into the DSM. It has been rejected. He'll keep doing it until they accept it, I'm sure. But it describes the behavior that is usually labeled as borderline personality. But it describes the behavior in the context of trauma and learned behavior and modeled behavior for people when they were children. So Croteau has recently written and edited a couple of pretty large textbook type books on complex PTSD. But then she recently published much shorter ones, about 100 pages, for clients and professionals, called "It's Not You, It's What Happened to You." So it's just a very nice, succinct description of complex PTSD and general principles of treatment. Dr. James Chu, his book is Rebuilding Shattered Lives. When I was doing my bachelor's degree back in the mid-90s, I ran into a professional journal article he had written called The Rational Treatment of Multiple Personality Disorder, and it has been my guide from the beginning. He's very big on not re-traumatizing people by getting too fascinated with alters and so forth. Alice Miller, who's now deceased, is quite famous for many of her books, For Your Own Good. Many of you might have had to read that one and some of the other ones that she wrote in your training. Babette Rothschild is a MSW in Northern California, I believe, and she is big in somatic work. And she wrote the book The Body Remembers, and also 8 Keys to Safe Trauma Recovery. I use that one quite a bit with my clients. It is written for clients. Peter Levine wrote Waking the Tiger and other books. His modality is somatic experiencing. And then Lenore Terre wrote Unchained Memories and Too Scared to Cry. This is all about the controversy about repressed memory. She's the one that kind of promoted that idea. Colin Ross, who I trained with, is a prolific author, pioneer in the treatment of dissociative identity disorder, ritual abuse, and such things. Very much involved now in the exposing of doctors who have participated in torture and other type things. He directed an inpatient trauma treatment program in Dallas, Texas. His book, The Trauma Model, in the year 2000 was a pioneering work. So if we adopt trauma-informed thinking or trauma-informed mind, what's going to change? This is my experience. So everything, of course, you're getting today is from my experience pretty much. Assessment, I've already kind of covered that a little bit when we looked at the ACE study. Assessment is all about getting that story and how do we ask what we ask. That's the big principle we need to think about. How do we ask what we ask? Do we avoid asking certain things? Are we not aware of asking certain things? Are we able to present things in such a way that we don't really put the person on the spot too much when we're first getting to know them or doing an intake, but we do acknowledge, validate, and affirm their trauma? The thing that I've noticed is, those of us who are very enthusiastic about treating trauma and about developing a trauma-informed mind and way of thinking, I've learned to understand that people aren't clamoring to get treated for trauma. People are doing the best they can and living their lives. When they end up perhaps in a crisis or some other situation, their child is acting out at school and they get called into school, the various life situations that come up, that's when they are asking for help or they need help, and many times not really even asking for it. They need help in putting their situations and connecting the trauma to their current ways of being in relationship, their current ways of coping. They need that help and understanding, and we need to know how to do that. So in assessment, that's a place that we can really look at how we ask what we ask. Diagnosis, opinion, and experience will change. I always like to tell people there are no blood tests for any of the mental health diagnoses that we use. It's based on self-report. It's based on our own training, our own biases, the way that we see things, maybe even the way we've experienced life. Those things may influence how we diagnose people, whether we're a social worker, an MFT, a psychologist, or a doctor. That will also influence how we see things. If we don't kind of narrow diagnoses and very often leave trauma out of the picture. We need to understand that in trauma-informed thinking, the diagnosis is not really emphasized. It's rather de-emphasized. And we begin to see things, again, in that injury model, that there is an external cause, but we don't want people, of course, to get stuck on being in victim mode. But there's a balance with giving a person a diagnosis, say depression, anxiety, PTSD, complex PTSD, bipolar, schizophrenia, whatever it might be. You need to pay attention. If trauma was involved, it has something to do with what diagnosis they are getting. In treatment, it's very much person-centered. If you remember your Carl Rogers readings, that's first and foremost. It's person-centered. All of our organizations, or maybe in our private practice, we may have a mission statement, we may have a way of looking at things, and sometimes a person will come into our realm that doesn't quite fit. And even with the trauma, I've worked with people that I've given them the trauma explanation. I think they have trauma. That doesn't really work for them. This way of thinking is still going to inform my viewpoint and my compassion that I exercise in my treatment with the person. Sometimes I may refer them to someone else if it's not a good fit. That's something else we need to really think about in treatment settings. Medication is a big, some places in this field. There are many people who have been medicated most of their lives from the time they were children, and now they're in their 40s, and they are becoming self-educated, and they're learning some of the harm that some of the medication has done to them. I've worked in places where I've been aware of people being on 13 or 14 different psychotropic type medications at one time, and this is just not good treatment. This is truly only looking at symptoms, and then, people will get one medicine for something, and then there'll be a side effect, so they'll get another medication to counteract the side effect, and on and on and on, until they're just medicated, and they couldn't even do therapy if they wanted to. So we need to pay attention. There are many studies out there. There's a hospital in Oregon where the medical directors took the lead in trauma-informed training for all the staff. They have cut down in their use of medication. They've had much better outcomes and feel that it's not that they don't use medication, but it's judiciously used. Outcome can change because how many of us have told people, this is a lifelong condition, you're probably going to be depressed all your life, or maybe deal with anxiety, or whatever the diagnosis happens to be. With trauma-informed thinking, we extend hope. It's recovery-oriented, and we are helping people develop resiliency. We now even have a phrase called post-traumatic growth. That's a big area right now in treatment of PTSD, of post-traumatic stress response, the term post-traumatic growth. Take a look for just a moment at a genogram for what we would call a traumagenic family. A traumagenic family is where this trauma is just generation after generation after generation. And so keep in mind that there's a lot of detail here, but it doesn't even include all of the detail. So the client in this example is a 24-year-old student who has come for treatment after a third suicide attempt. She has had problems and treatment for alcoholism. She has engaged in self-harm from the time she was a teen. There's disordered eating involved. She's now on academic probation as a student. She has a history of abusive relationships. So let's look at her family. Her mother and father were married for 7 years. They divorced in '97. There was domestic violence from the father onto the mother. The father was a police officer, dealt with alcoholism, cigarette smoking, a lot of anger, and early heart disease. The mother works in the clerical field. She's been in recovery from alcoholism for 6 years at the time of the student coming to you. She's been married 2 more times, sorry. One of those, the husband completed suicide. The husband, her ex-husband, the patient's father, has been married a couple more times as well. His second marriage, the woman had an overdose of cocaine. He's now married to a younger woman. They have twins. One has autism spectrum disorder. In the second marriage, the father had a son who, at 15 years old, perpetrated sexual abuse on our client at her 5 years old. So this is not uncommon at all, this genogram. I very often genogram and create a genogram usually around second or third session, and I'll do them by hand. It's very interesting that, especially with one like this, you can show it to the person. I always say there's a lot of energy on the page, a lot of detail, and a lot of things going on, and you can see, in your client that's sitting in front of you, usually a lot of anxiety going on that may reflect all this energy. So this is a very important tool, but I really wanted you to see kind of on paper, again, I'm sure this is not uncommon for most of you, what we would call a traumagenic family. So here's some principles of trauma-informed mind. Harris and Fallett wrote a paper creating cultures of trauma-informed care. And their approach to organizational change is built on 5 core values: safety, trustworthiness, choice, collaboration, and empowerment. So we're not only talking about in the treatment about the physical setting of whatever the agency is that the person will walk into. There are certain elements. We have all these rules about HIPAA, privacy. We have wonderful mission statements on the wall. But if a person walks into a facility, into a waiting room, and it's unkempt, and people are standing out in the waiting room, maybe a clinician standing there talking to a person about their issues, there are many things going on there that are not really establishing safety and the ability for a new person to come in and then trust what's going to happen there. Many times people don't get choice. Again, the mission statements may say they have choice, but very often they're not getting choice. So this has to do with, in each contact, as the writers say, in the physical setting, the relationship, any activity, that it's evident that the experience of the staff as well as the consumers are engaging in all these 5 core values. And then Howard Bath came up with what he called 3 pillars of trauma-informed care. Again, we see safety is involved, connections, and managing emotions. There are many people writing about this now. I have a Google Scholar search that I get articles every day, scholarly articles from the newspaper, various places where trauma-informed principles and trauma-informed thinking is being promoted and spoken about. How can we develop trauma-informed mind? This, again, is my way of looking at things. This is something I teach my clients pretty early on. It's kind of a mindfulness activity. It's the element of mindfulness. We pay attention to our thoughts, our feelings and emotions, our body sensations, and our behavior, our urges to behavior. So what do I mean? How do these things figure in developing trauma-informed mind? So I personally have worked in places where, people always ask me, isn't your work hard? Isn't trauma work hard? I'm like, no, I love to work with the clients. What's difficult for me is when I have to work with other professionals who seem to be extremely judgmental and dismissive of clients and patients. I've worked in those places. I'm sure some of you have too. So what are our thoughts about our fellow human? This is where our compassion comes in. Do we see that people are doing the best they can to get their needs met at any given time, even when they're acting in so-called manipulative or annoying ways? And we see in the context of maybe the trauma that they've experienced that the way they're acting is what they know. What are our thoughts about that? What are our feelings and emotions about trauma in general, about our own issues and experiences? We all have them. Have we looked in the mirror? Have we been able to clearly identify, gosh, I'm sad and mad about whatever this thing was that happened to me, and really allow ourselves to express, process through, and work through those emotions? We need to be aware, because this is a very tricky subject. Trauma is my first job at a hospital in an outpatient program, I had to learn to say grief, loss, and anger issues because my supervisors didn't want to hear the term trauma. And so what are our feelings and emotions about being trauma-informed and about looking at trauma with people? What do we feel in our body? Are we connected to our body? Again, this is something I teach my clients to do, and I need to be doing it as well. This figures in with countertransference. If I'm sitting with a client and they're telling me something that triggers of mine, I need to be aware and do some breathing and put that aside until another time. I need to be aware of those things. And our behavior, how do we engage in our own lives? How do we care for ourselves? If we're engaged in active addictions, in abusive relationships, chaotic relationships, if we're unable to set boundaries in our own personal lives, that behavior is going to spill over into our work in trauma-informed work, and we're going to have difficulty really developing trauma-informed mind. Where is this needed? It's needed, quite frankly, anywhere that humans interact. We all need to have more compassion for one another. We need to be able to smile at one another. We need to be able to understand that we're all having difficulties and we're all able to have joy if we can lighten up on one another a little bit. So this is why I say that it's anywhere that humans interact. So in the macro and micro worlds, such as hospitals, treatment facilities, community support facilities, homeless shelters. There are homeless shelters throughout the country now who are instituting trauma-informed training. Private practice settings, of course. We need to be aware of various things in those settings. I personally have worked in both macro and micro settings where trauma was treated, but in my opinion, trauma-informed thinking was not present in the facility or the environment. One place that I worked, part of our job was to do groups with people who'd had trauma, and people are going to cry, but we could never get enough Kleenex for the groups. The hospital facility where perhaps people were aware that their insurance was paying up to $1,000 a day for them to be there. We couldn't get enough Kleenex. The hospital facility wouldn't allow us enough Kleenex in the facility to deal with help the clients. And so that's just a little thing, yes, but it is something that indicates where our thinking is. The court systems are beginning in some places to institute trauma-informed treatment thinking. So are police departments, many schools, universities, and administrations, and in jails and prisons. Here in San Diego, I believe some of the prisons, they're using the Seeking Safety curriculum. If you've heard of that, it's a wonderful curriculum for treatment of substance abuse and trauma. So this is a graphic regarding the ACE and what's happening with the ACE around the country. There are states that are using the ACE study and doing their own versions of it. So this is what was happening just a couple of years ago. I wanted to bring attention to a town in Florida that has declared itself a trauma-informed town. The town of Tarpon Springs, right outside of Tampa in Florida. They have some wonderful videos up on YouTube. I would very much encourage you to go to their website and their YouTube videos. On a community level, get all their personnel trained and thinking in terms of trauma-informed, both in response to crime rate and health statistics and other things that are going on there. They wanted to institute trauma-informed thinking. Dr. Sandra Bloom created the Sanctuary model. This is an organizational model of change. It started as a treatment model, but has been developed into an organizational model of change. She is on the East Coast, and if your organization has up to, I believe it's 17 or 8 send at a time, you can send them to get trained in the Sanctuary model. I'm going to read what she says because I think it's so very important as to what can get in the way of developing trauma-informed mind. Training programs and degree programs, etc., are still woefully deficient in conveying the research data to the people who need to know it. Trauma training is not about the seemingly simple problem of giving people information. The real problem is that the material is challenging, threatening, and it may elicit resistance, change, and denial within individuals and within entire systems. So when I'm doing trauma training, I emphasize to people that this is really about changing our hearts and minds about our fellow human. Too often in various settings, we can, as a defense, we can kind of develop an us versus them viewpoint, and we can look at a person who's very ill in a mental illness condition, and we can look at them and think, you know, at least on some level, that'll never be me. But anybody, unfortunately, anybody can go through some kind of trauma, get a traumatic brain injury, and it changes your life. So this is about the human condition, and it's about that application of compassion and growing in compassion in our lives and allowing ourselves to challenge ourselves. If we're a true believer already, I encourage you to, you know, keep speaking up because it does do some good in places where I have worked and, you know, in a derogatory way being called trauma queen. I now get calls from those folks when in consultation sometimes. So things do change, people do change, and people do listen eventually. So this is our biggest defense again. We have it, our clients have it. We don't want to think about this sometimes, but really it's all around us, and we do need to take off that armor. I want to talk for just a couple of minutes about self-care. When we work with trauma, whether we're treating trauma, whether we're providing outreach services, case management services, whatever kind of services we may be providing, if we're even just aware of the trauma that people have been through, this can really get us down. It can change our viewpoint of our view of the world. So the term it's different from compassion fatigue and burnout. Burnout is really about being done with your job. Compassion fatigue is exactly what it says. Vicarious traumatization is a condition that can develop for therapists often, but other people as well. That is kind of a secondary PTSD because you're hearing graphic details of abuse, or at least aware of graphic details and the bad things that go on in the world. So we need to find balance in our lives. We need to make sure that we're doing what we tell others to do. I like what this last, our second paragraph says. It says vicarious trauma is the emotional residue of exposure that counselors have from working with people as they are hearing their trauma stories and becoming witnesses to the pain and terror that trauma survivors have endured. So these are the kinds of things we may encourage our clients and patients to engage in, but we also need to find some of these things to engage in. Meditation, some kind of very simple form of meditation is very helpful. I always tell people you can go on YouTube and find all kinds of free guided meditations that are great. If just sitting and breathing doesn't work for you. We need to take care of our body, yoga, massage, exercise, all these things that we can put in our lives, either playing music, going and listening to music, participating in music in some way. Do we have a spiritual life? That looks different for every one of us, but this vicarious traumatization especially affects our view of the world and our view of life and our view of having meaning in life. And that all has to do with spirituality. Do we have family and friends and people that we can turn to for support? Especially if you're a therapist, people are leaning on you basically all the time. And where do you get to have that? Fun is very important, as is creativity, reflection, and when you need it, supervision and consultation is very important. just having someone to talk to, sometimes to vent. We all need to vent, even when we're being compassionate. Sometimes we just need to vent a little bit. But do we have a private place that we can do that? So I came up with a few phrases that I think are important for people to know, things that, interestingly, some of these things I've been saying for years, and then I'll read someone else's article, and there are my words in their article. So what's wonderful to me about this is when that happens, I see this as really a spiritual movement that's happening in the world today. I didn't just come up with these things. Other people have been thinking about this too. So explanation, not an is a good phrase to understand when we're especially talking about traumagenic families or transgenerational experiences that people have with trauma. Very often people will say, well, my dad can't help that he beat me. He got beat every day too. Okay, well, that's an explanation, but it's not an excuse for hurting children. And then that allows and opens the way for the person to be able to fully express themselves, the anger, the sadness, the confusion, the betrayal they may have felt when they were a child that they didn't get to express, that may be getting in the way of their life now. I've already talked about traumagenic families. Big T, little t trauma, that comes from EMDR, Francine Shapiro's book. That's where she came up with this phrase, big T, little t. Big T, maybe I always think in terms of the things that, if you're a mandatory reporter, those are the big T things that you have to report. The little t is everybody has some little t trauma, and that's the context, I think, very often for big T trauma with people with complex PTSD. I like to think in terms of no matter what people are doing, they're trying to get their needs met. That they're, nobody, in my opinion, wakes up one morning and thinks, how manipulative and how annoying can I be to everybody in my world today? People are just trying to get their needs met and doing the best they can with what they know how to do. And if what they know how to do comes across as manipulative and annoying, then learn different ways. We need to gently challenge them with humor and compassion and help them find other ways. If you've never heard about complex PTSD or complex trauma, I strongly encourage you to look that term up and go to Bessel van der Kolk's website. He has many, many articles there about working with children and teens and all kinds of things that you can print out for free. Amygdala hijack, this is when that primitive part of the brain tells us that we need to fight, flight, or freeze. We need to be aware of that because many people in our presence will be in amygdala hijack, and if we don't know what that is, we might try to start talking to them. We might do things that are not very helpful. We might judge them. We need to understand that when a person feels triggered again, that this may happen, and we need to be able to help them breathe and get grounded and so forth. Trauma response is a term that I use for some things I teach about what happens when a person goes, especially through childhood trauma. I call it self-blame as a coping defense and ambivalent attachment issues. If you want to know more about those, I have additional trainings. Those are whole-day training. But I call those trauma response. When a person responds to me in certain ways, even when they're personalizing it, I often will see that, they're coming from a place of low self-esteem. They're coming from a place of blaming themselves, but the way it's manifesting is they're attacking me. When I understand that, then I don't have to personalize things, and I can kind of detach and help the person with their issues versus personalize things. So the last thing here in our presentation, I came up with a little list of trauma-informed mind ethics. I'm just going to read these due to time. I will strive to apply compassion in all my relationships, to be aware of my own trauma-related issues, to establish an environment of safety, physical, meant that I can, to work in balance, including balance in my own self-care, to offer hope and focus on strength. I will strive for balance and boundaries, respecting that those I serve need my support, but also need assurance that they are capable. I will strive to treat with respect those I serve and those with whom I serve, even if I don't agree with them. To keep up to date with developments in the trauma-informed field, but refrain from holding up any one method or modality as the only or right way. There are new developments every day, and we need to keep somewhat up with those and not just get stuck on one modality as far as treatment is concerned. And I will strive to offer education, support, practical tools, and resources. So if any of you want a list of the specific resources for this presentation, you can email me at my name, Kathy, C-A-T-H-Y-S, Harris, LCSW, @gmail.com. Go to my website, Kathy S. Harris, LCSW.com, or my training website is Trauma Revolution. And there are ways to contact me through all of those means. So thank you very much for your time. Apologize for my technical difficulties here. I hope that I gave you some information that was helpful. And please feel free to email me. And if we have time, I'm not sure if we have time for any questions or not.
We have time for questions. If you look in the chat section, people are asking questions.
Okay.
Elon is asking you to repeat the email address. You may want to type it in, your email address.
Okay, I can do that. Good. The name of the author for the complex trauma book is Christine Courtois, Courtois. Let's see, whatever. Okay, I'm not seeing any other questions coming up. But thank you as well.
Hi, everyone. Okay, so I'm putting myself back on because I'm realizing there's no question, but a lot of wonderful feedback from everybody. Oh, and Rasael is asking if you're going to provide a copy of the PowerPoint. ShrinkSync will do that. Kathy, are you okay with us having your PowerPoint presentation included with your audio placed on our website and yours so they could review this if they wanted to? Kathy? Oh, she probably can't hear me then. I don't know. Kathy, can you hear me? Oh, she's typing. Okay, so we'll wait to hear from Kathy about that, but it should be on our website with the audio recording and just waiting for approval though. So we should have that available. And then Terry's asking a question, Kathy. Okay, so Kathy will have it available on her website. It'll also be available on ShrinkSync's website. So you'll have a copy of all the slides as well as the audio recording. And Kathy, Terry's asking a question. Okay. So for right now, as she answers that, for right now, I just wanted to thank you, Kathy, for an amazing presentation. I thought it was so informative and so useful, and I just really enjoyed your style and the information you provided. And I did want to thank everyone for your patience again and participating. And for our next, I already mentioned the digital networking webinar will be in 2 weeks on Tuesday. And our February webinar is going to be presented by Mercedes Samudio, and she's going to be presenting on navigating your kids' digital life. And that's going to be on Tuesday, February 17th at 12 o'clock. Right when you guys sign off, you're going to receive the evaluation to complete. And as soon as you complete that, within a 24-hour period, Rachel will send you your CEU certificate. Thank you again, and sorry for some of you who had troubles with the audio. And I don't know if there's questions that Kathy is answering or not, but feel free to email Kathy with questions. She'll be more than happy to answer those, it sounds like. So thank you again, and don't forget to use ShrinkSync for client referrals and CE postings. We'll see you next time.
Actually, I didn't mind that at all. I wonder what happened with this stupidness. So annoying. Oops. Now, I can't hear anyone.